past history of ATT and your patient is having active symptoms, because as Dr. Verinder said, these are molecular tests and they may remain positive, the DNA may remain within the body tissues. So you may have a positive trace test and still the patient does not require ATT. So only if it is a new patient and there are clinical signs and symptoms of tuberculosis, that you can make a diagnosis of MTB with a trace test. Now coming on to its validity for rifampicin resistance on a trace test will not be there, because such low bacillary load RPOB gene mutation would not be, it won't be able to tell whether it is sensitive or resistant. So don't rely on the rifampicin resistance report, but obviously the diagnosis of MTB depending upon the clinical scenario of the patient.
So trace calls means that you get a trace result and then you have to correlate it clinically. It may not always be tuberculosis. Clinical follow-up and doing a culture is something which will help you in management. And then the second issue, as ma'am has talked about, is that if you have a very low level, so with trace you get resistance which is indeterminate. Indeterminate means that the machine cannot detect it, right? It is not that ki resistance hame pata nahi hai, right? It cannot detect it, that is what it means. Very low with arsen resistance is something which we'll have to work upon, and it needs to be repeated. The test needs to be repeated because the specificity of the test goes down, right? Am I right, ma'am?
This is important, if you have a test, like this is interpretation of CBNAT. So CBNAT, the result which is available is high, medium, low or very low. If it is drug sensitive, then you go ahead with drug sensitive treatment. Now the problem comes with very low with DRTB. That is, if it shows very low and it tells us about rifampicin resistance. So rifampicin resistance, if there is a prior history of ATT, then or it is a retreatment case. That means or case of child living with HIV, or there is a child who has a contact, as in this case. Now there is an uncle who had a history of ATT. In such cases, even very low, you have to keep in mind that it could be DRTB. So what is required in all these situations when it comes out to be very low and it's a new patient without any risk factors, then we start DSTB treatment and we send the test for culture.
Yeah,
or we send it for the repeat test, retest.
So you follow up the child, start DSTB treatment. If you're confused, do refer the patient to an expert who can handle it. But what we're trying to say is when the bacillary load goes down, if it falls to a trace level, then even the MTB is plus minus, right? And if it falls to a very low level, then MTB is possibly there, but the resistance to rifampicin, the specificity goes down, and you need to look at the clinical scenario, right? Am I right?
No, so for trace, I would say that was not right what you said. For trace, a prior history of ATT is important for expert ultra. So if the patient has not had any prior history of ATT the last 5 years, then obviously a trace for MTB should be taken as MTB positive. But it won't be able to tell you about the resistance.
Yeah, agreed. So it does not tell you about resistance, but if it's trace, then you have to look at the clinical factors as well.
Exactly.
Because in many cases, it doesn't correlate clinically.
Yeah.
We follow up the child clinically and we depend on the culture as well.
Yeah, if you just get offhand ultra report without clinical scenario matching with tuberculosis,
then we treat it.
Then you have to ignore such a report.
No, if it is matching with your tuberculosis clinically.
Matching with clinical scenario, yes, but often, in our clinical
yes, it doesn't
practice,
match.
We find all of a sudden, there is a ultra report and the symptoms, they do not match with tuberculosis. Then obviously you have to ignore it because.
Yeah, agreed, ma'am. So I think Dr. Singh has a comment and then we'll move on.
I just wanted to say, while we are speaking, when we say ultra is to be taken with a pinch of salt or take in the context, we are only talking of ultra trace calls. We are not talking of ultra any other calls. So that is the only clarification. And other thing is, which is important is, you may wonder if MTB is not questionable, why is rifampicin resistant questionable? It is not detecting sensitivity or resistance. It is only detecting resistance. So report says rifampicin resistant not detected. Inference is it is sensitive. It is not saying, it is not looking at sensitivity. Therefore, you do not have enough copies of the gene, the mutation of which will tell you it is rifampicin. So it is not able to detect resistance. So it is indeterminate. That's how we must understand it. We think in terms of cultures and therefore we get to it.
Okay, so very few minutes left. Dr. Kamal, Dr. Sangeeta ma'am has already talked about moderate complexity NAT, which is a newer test. So few questions that, do you actually need to look at INH resistance? Yes or no upfront? Why do you want it?
Yes, of course. Because, again, the fact that we were looking only at rifampicin resistance for so long was that we did not have a test which could give us easily the rest of the things also. So now that we as ma'am said, the PathoDetect is something made in India, easy to get test done, does very rapidly. So if you have the rifampicin resistance additionally available, that will be a lot of help. For example, if you look at this data, the INH resistance, when the rifampicin susceptibility is there, it's as high as 13% in new cases and 17.4 in previously treated cases. So we have a regime for INH resistance also, but till now we did not have an easily available means to look for that. And now with this PathoDetect thing, we can rapidly get that information.
Okay, so the need is there because a lot of patient can have INH resistance and the regime might be a bit different. So that's one, and this is what the data says, right? The next question in briefly is that what is the sensitivity and specificity overall for these moderate complexity NATs? Does it match with your expert? Are they inferior or they are superior?
So the sensitivity specificity is almost as good. The sensitivity is almost, the pooled sensitivity is 93% and specificity is 97.7%. So they are as good.
Okay, so great, thank you. So we understand that these are good tests. We don't have rest of the test available as of now. We might have them later. Hence, we are not very clear about the cost and the complexity. And when they get available, we'll again talk about it. The PathoDetect has been approved by the program, and it is something which we can consider. Okay, so there are two tests which are very confusing, LAMP and LAM. So in 30-40 seconds, please.
Try to throw light through LAMP. LAMP is isothermal loop amplification test. So it's also a DNA test. It is good because you can do it periphery. It is easier to do. The trouble is it only tells you MTB. It does not tell you RIF resistance. Otherwise, it is similar to it. So UV LAMP, when you go, you will lose the information about rifampicin. It will only tell you MTB.
Is it equally sensitive?
Almost.
Okay. And what is this LAM?
LAM is when you look at lipoarabinomonocyte, which is part of the wall in MTB wall. It's like an antigen detection, not looking at antibody detection. So you measure that in urine. So there are lateral flow tests which have come, lateral flow silver tests, which are good. So this is simple because you can do it on urine. But the trouble is that its sensitivity is so poor that it can pick about 30-40% off only amongst co-infected. So far it is only recommended when you have HIV, TB co-infection. The sensitivity is not so great that it is recommended for other situations. Possibly future generations of LAM may take up.
So as of now, for HIV status not known or negative, we don't use a urinary LAM as of now, right? Am I right?
We use a combination because your expert will give you more answers. So you do expert, but then they have many other OIs, repeated testing may not be. So in addition, you can use urinary LAM, which may add.
But not as an isolated test. Okay. So the follow-up of this child, so this child was evaluated further. So this child is found to be rifampicin resistant. So ma'am, what are the follow-up tests which you do? We just have 30 to 45 seconds, I am sorry.
Yeah.
Will be thrown
You know,
out.
I would just like to add for, LAMP, just a single statement that it can be used in place of smear. So, LAMP, Now coming on to the follow-up test, as Kamal has said, universal DST means that whenever you have rifampicin resistance, then you need to go a step further. That means you need to know the FQ resistance, because all the regimens, they are based on uh, FQ status, whether it is sensitive or not. So we have these low complexity NAT, that is expert XDR. This is a new test which is emerged. Now this is also, it gives results in one day, and it tells us about INH, FQ, second line injectables, as well as ethanamide. But ethanamide sensitivity is poor. Then we have LPS, Dr. Virinder has already said, first line and second line LPS. And then obviously we have the, the targeted next generation sequencing. So this is one thing which is coming up right now. There are two major companies. One is Illumini and other is Mpure. So, over here I would like to say that this is different from whole genome sequencing. Whole genome sequencing requires a culture. First you have to obtain a culture, and it can only be done on culture. But because it tells about the whole genome of the MTB, so you can detect all the resistance. But we do not require all that in our clinical practice. So that is the test which is reserved for surveillance.
Okay.
So for targeted genome sequencing, that can be directly done on sputum smear. And you do not require any culture, and it